Okay. Can I welcome members, invited guests and the public, both here and those watching on the webcast, to today's meeting of the Health Committee. Our main item today will be looking at holding a one-year review of the Health Inequalities Strategy. We encourage anyone taking part in the discussion on social media to use the hashtag AssemblyHealth and hashtag Health Inequalities. First, there's a few bits of business that I want to go through. Do you have any apologies?
No, Chair.
Thank you. Can I ask members to note the list of offices set out in item number 2 of the agenda, and ask any members if they have any interest to declare?
Noted. No.
I was just going to say that I champion the healthy early years work, and I visit nurseries and schools on behalf of the health team.
Thank you, Joe. And I know this is part of your remit as Deputy Mayor, Second Deputy Mayor, and also a very key responsibility which you carry out on behalf of the Mayor. Thank you very much for that. Can I ask the committee to confirm the minutes of the meeting of the committee held on the 10th of October 2019 and 6th of November 2019 to be signed by me as a track record?
Great.
Thank you. Can I ask the committee to note the completed and outstanding actions arising from its previous meetings and additional correspondence received? Thank you. Can I ask the committee to note the recent action taken by me as chair under the delegated authority following the consultation with the deputy chairman, namely to agree the output of the 10th of October 2019 meetings discussion on insecure housing tenure and impact on children's health, attached as Appendix 1. The committee's report on connecting up with care, and also note the attached report as Appendix 2.
Great.
Thank you. Well, that brings us to today's main item, where we'll be questioning invited guests on the Mayor's Health Inequalities Strategy, and this is a year on after his publication of that strategy. Can I please welcome our guests? First, Dr. Nicole Kleinman, Public Health Consultant, London Borough of Hackney and City of London Corporation. Welcome. Dr. Jessica Allen, a Deputy Director at the UCL Institute of Health Equity. Thank you. Welcome. Professor Paul Plant, Interim Statutory Health Advisor to the Mayor. Dr. Tom Coffey, Mayoral Health Advisor to the GLA and to the Mayor. Dr. Vic Divakar, Regional Medical Director for London and NHS England. Welcome. And also Neil Churchill, Director of Experience, Participation to and Equalities, NHS England. Thank you. Welcome to all the guests. We will try to finish by 4 o'clock if we can, because I have another meeting after. But if we can't, if we run a little bit later, so be it, right? But let's try to be very focused in our responses, and we'll try to keep you very tight, right, in your responses too. So I think it's appropriate that we start off with Dr. Tom Coffey, because this is the Mayor's strategy we're reviewing, and as you are the Mayor's appointed advisor on health policy in London. So can you please share with us what you think, how the Mayor is ensuring that the London-wide strategies such as health and care vision and health inequality is being delivered in London. So if you could just put the context to us, please.
Okay. So first of all, thank you very much for inviting us today. And we're only kind of just over a year into the Health Inequality Strategy. So we would like to use this session, if possible, to glean from you information and direction as we go for the next 9 years. Just for us to put some kind of context in, is because London is quite a healthy city. And when I was looking at the life expectancy of London as compared to England, so a man at the moment in London perhaps dies about 80.7 years, the rest of the country 79.6, women 84.5, rest of the country 83.2. So Londoners live longer than the rest of England. Also, in the rest of the country, there's been a bit of a stall in the progress of how long you live. Not the case in London, 0.2 years. Also, the health inequalities, which we're talking about today, the gap in London is much lower than the rest of the country. 7.2 years compared to 9.4 for men and 4.9 compared to 7.4. So we live longer and there's less health inequalities in London. Now, these are the figures for 2017. So they're perhaps the first 1 or 2 years of the Mayor's term in office. But it doesn't reflect the actions of the health inequality as yet, because the data is always a bit lagged. So what we'll be sharing with you is very much what we're doing, and we would expect the impact to be measured thereafter. The boroughs also have a very interesting kind of position, whereby there's a very difference in improvement in life expectancy in London. There's only 2 boroughs in London where both men and women have had improved life expectancy over the last 4 years. Just 2 boroughs.
Which 2 boroughs?
I'm glad you asked me that one. Okay, Barnet and Camden. So therefore, some have had just the men, some women, but only 2 boroughs have had improved life expectancy over the last few years. We've developed an implementation plan, and that was very much a request directed from yourselves. Our first draft perhaps lacked a bit of detail that you asked for, and that we'll be obviously analysing today. So the approach the Mayor has taken to say, how can we deliver this health inequality strategy? How can we work with our partners? So the approach is numerous. First of all, the Mayor can just do certain things. So the things which he does directly is, let's say, fund mental health first aid training in schools throughout London, or introduce the ULEZ zone, which improves air pollution. I think there's been a 35% drop in nitrous oxide in London since 2017. And we know in London, the poorest people breathe the poorest air. Then there's about convening. The work is done on HIV and hepatitis C. Can we convene the system in London to address the health inequalities in HIV, hepatitis C? And then about leadership, social prescribing. 5 years ago, no one had heard of social prescribing. It was something Sadiq championed. It's now part of the national contract, and our ambition to have every Londoner, receiving social prescribing if possible, is well on track. Then it's about advocacy. How can he do advocacy role to make sure we deliver what we want from our HIS? And his role is very much with partners and the government. PrEP is a good example, which is pre-exposure prophylaxis for HIV, which perhaps wasn't as extensive in London as we'd like it to be. It's advocated tirelessly to ensure that is the case. Or as a public health grant, how do we make sure, if we want to talk seriously about improving the public health of Londoners, you've got to invest in that. And he's been a very keen advocate to ensure the reversals of the public health grant cuts are turned around. Next, it said health and all policies. So how can we do it by making sure it's not just what the health team do, it's what the transport team does, using TfL's ability to ban advertising for unhealthy food on the tube network. Our planning. How can we use our planning to ensure there's no fast food takeaways within 400 metres of a school? And finally, our partners. So we in a GLA, albeit our health and all policies can do a limited amount, but we need to work with our partners at NHS, business and schools to deliver. And how we've done this, one of the key vehicles we've done this is via the London Vision. So when we started the London Vision, it was a refresh of a proposal delivered initially by Aradazi 5 years ago to say, what will the 10 priorities be? And I was a bit anxious it will be cardiac surgery, asthma, very important areas, but in fact the vision has chosen areas aligning very neatly with our health inequality strategy. Childhood obesity, violent crime reduction, smoking. So therefore the vision of the NHS, a partnership between social care and the healthcare, we feel is a significant vehicle to deliver our HIS. Also, you'll see that we have tried to work with our partners. They've said to us, don't tell us what to do, give us a guide and give us a menu. So therefore, we've done a guide for the voluntary sector, for the local authorities, for the NHS, for business, to say, these are our HIS priorities. These are the things which we know work. Do you want to do these? And you'll find Camden will do something very different to Barnet. They'll address what they think is important for their local population. What we can give them is a menu of opportunities that we know can work to address health inequalities. We are organising workshops to make sure also the learning is shared quite widely. One area which we feel we've worked with the NHS a bit, and which is a difficult one to start with, about challenging and championing NHS, is Sadiq initially looked at some STP plans a number of years ago, and they were not up to the standard he would have liked. There was a number of gaps in them. So I developed what is called his SK6 tests to say every single reconfiguration in London, which is significant, I will use these tests to assess whether they get my support or not. The STP plans coming out in the future, I'll use those 6 tests. One of those 6 tests is to assess the impact on health inequality for that reconfiguration, for the STP plan. So he can use his influence and leadership to ensure that these areas are focused on. And in fact, what we found, even in advance of that, people are coming to us to say, we're developing these changes in our area, let's say Epsom and St Heliot as an example. We want to make sure that we're going to be compliant with the SK6 tests. We want to make sure that we're going to address health inequalities. So that process in itself, we believe, is having a significant impact. Devolution also has given us some limited opportunities to make changes. The sugar tax and how some schools are using the sugar tax to get water fountains and supply of water, and really supporting the idea of water-only schools. The way devolution to the boroughs of the control over advertising. Can they follow the leadership set by the mayor on banning unhealthy food advertising on the tube network? So therefore we've been very clear to try to find a framework and a process which allows not just us in health and the rest of the GLA, but the wider determinants of health throughout London to deliver the Health Inequalities Strategy. And you asked us a couple of years ago, how do you know that what you're doing is going to work? Can you please develop some key performance indicators? So what we've done very clearly is to look at 14 areas that we're going to monitor. So each of the 5 commitment areas has got its own performance objective. Healthier early years. Can we get 1,300 schools signed up by the beginning of this year? We've already done that. But also 14 key kind of population indicators which will allow us to judge ourselves and be judged by Londoners, are we achieving? I'm going to hand over to Professor Plant, who might just, if you would like it.
Do you think healthy living years is a better marker of inequalities rather than healthy life expectancy? And how's London doing on healthy living years rather than life expectancy?
I'm going to hand that over to Professor Plant.
So we measure both, and they both follow the same trend. So it doesn't really matter which one you select. I think you're probably right. If I was going to have an indicator of the well-being in my population, I would go to years of life free of disability, which I think is what you're getting at. But the trends are the same, so it doesn't matter which one you choose in that respect. This overall trend being that London is booking the national trend here. And actually that trend of stalling in life expectancy is international. It's not just in England, it is international. And colleagues in nationally in PHE have been working with other institutes around the world to try and understand that pattern and the demography and the drivers from that. But specifically to your question, if you was to ask me personally, there is a whole raft you have to understand, but that is, yes, it is a good one to know how long you're going to live without a disability.
Okay. Dr. Coffey, the delivery of the Mayor's health strategy relies upon working with other partners. How alive are the other partners to your ambitions? Do they take it into the consideration when they're doing their work, or do they ignore it?
Okay. So the short answer is yes, but let me try to evidence that. So I'll start with the local authorities. So often the leadership in this area within local authorities is health and wellbeing boards and the public health director of public health. So I've had meetings with the health and wellbeing board chairs. We're very keen to take our guides to implement them accordingly. I've met with the DPHs across London, and not out of my asking, they have requested our presence to say that this document we feel will form our work over the next few years. With the NHS, and there's 2 areas there I would like to focus on. The first is looking at the long-term plan. The long-term plan, which came out last year, identified health inequalities as a key new area to focus on. And my plea to NHS was, don't start again. We in London have developed a health inequality strategy 2018 for the next 10 years. Can you please work with that to deliver your health inequality strategy for your CCG, for your SDP area and for London? And they've agreed to do that, so there is enormous synergy between those two plans. And the point I made earlier, I suppose, about the vision. The vision, has embraced the health inequality strategy priorities. Each area will have a work plan. The NHS is going through a review of its Health London partnerships, and it's committed funds from that review to the delivery of the London vision, to have the organisational architecture which will make it work. So I believe there is a commitment, evidenced by the work plan and the finances to deliver it with our partners.
Dr. Nicole Clement, when you are setting, say, policy in your boroughs or around London, does the Mayor's strategy have any bearing on the work you do, and so in which way?
Yes, absolutely, and all of the things that we've talked about are reflected within some of our plans, both the council and within public health itself. I think what we haven't talked about is working with the NHS, and I think that is really the key through integrated partnerships, integrated commissioning, and how sort of newer ways of working, because I think a lot of these things cannot be delivered just by local councils, and I think we really need to form quite strategic partnerships at a local level. I think there's absolutely the commitment. I think there's still ongoing challenges. And, I can look through the list and think, yes, we're doing well, but some of these things, we could do better. But I think having the Mayor's vision, the Mayor's strategy, absolutely helps take some of these things forward.
Dr. Allen, did you want to come in at this stage, or to give an overview about your view, how it looks from your your unit?
I'll just say a couple of comments. Firstly,
Yes.
about the national picture, and it's true, life expectancy stalling, health inequalities are widening, which is a really serious outcome, and it's quite recent. So we've looked at various explanations as to why that might be, including cold winters and flu, and it's not those. So it's likely, given all the evidence that we see, that the explanations for the stalling life expectancy and widening inequalities lie in what's happening socially and economically and culturally. So those are the arenas that we at the Institute are really looking at as to what can be done. Now it's true, London has slightly bucked the trend, and actually London is, on many measures, the healthiest region in England. And has improved to a certain extent. But when you really unpick and look at small areas, the health inequalities are really, really significantly much wider than the averages between boroughs. So looking at some of the smaller area data, we see life expectancy differences 16, 17 years within boroughs. So clearly the strategy needs to really focus on those areas which are doing much worse, and they're quite small neighbourhoods often, especially in London, where you get great inequalities in wealth, cheek by jowl. So that's one comment. And secondly, these health in all policy and the mechanisms which underpin them, which have been described, absolutely central to work on health inequalities, as I've just mentioned. Most of the reasons for health inequalities lie in social, economic and cultural factors, some to do with the NHS, but not so much. So having these cross-sector mechanisms is central. Some of the other areas we've worked in have gone even further with that, and be interesting to explore. So we're working with Greater Manchester, Coventry, just one local authority. So yeah, there's other sectors that need to be involved, and health inequalities cross-sector mechanisms which could, I think, be strengthened.
Great. Dr. Divarkar, I mean, how does the NHS respond to the health strategy?
So the first thing is, I think the health inequalities strategy is absolutely central to everything that we're doing in London as an NHS. So part of the purpose of developing the vision for London, which we launched at the London Health Conference last October, was taking the Mayor's health inequalities strategy and the leadership that City Hall has provided, taking the 32 boroughs and their own plans, taking the NHS long-term plan and what we have to deliver, and putting all of that together with Public Health England's expertise it really represents the combined activities that all of our different institutions are working together on, where if we did them and worked effectively at a London level, we could move further faster towards the ambitions that are set out in this. And part of the development of that process was starting with the Health Inequalities Strategy and making sure that we were completely consistent with it. And I think the impact of the London vision in the NHS has been, very practically speaking, we see it as being a set of guiding principles that are guiding all the work that we do. In my regional executive that I sit on every month, we get an update on where we're going with it and the activities we're undertaking on it. It appears in all our staff briefings. We meet every month with all the chief executives in London and talk to them. I meet with medical leaders in London on a monthly basis and we give them an update every month. If you look at the early work that's been done where our local health systems, if you like, are engaging with their staff and their communities about plans that the NHS has got to deliver on the national NHS long-term plan, you'll see in that there is a chapter in each of it on the London vision. And because the London vision is completely aligned with the Health Inequalities Strategy, you've got that alignment going through our communities as well.
Thank you. Did you want to say anything, Mr. Churchill?
So I'm working from a national perspective rather than purely in London, but I would say one of the things we're looking to do is to build and communicate the evidence base about what works in terms of interventions, and we have been able to draw on a number of examples from across London where things are working in specific areas, so places like Tower Hamlets and Lewisham, places like Kensington and Chelsea in terms of some of their community champions work. And others, but we do have some areas where we do need to learn more, and I think the overarching lesson is that it's the priority and the culture which are most important in getting this right, but there are some places where people are struggling with quite long-standing and pretty entrenched inequalities, and working with partners, and including the voluntary sector, who I think have got a key role to play in this, is also important. So we are building the evidence base too, but there's been a lot to draw on.
And the health board, is that the place where the mayor has clout with his partners?
Okay, so I'll answer the format when I come in as well. So the London Health Board, which is the chairs, and we've got the 5 local authority leaders and key leaders from health, is the area which really has oversight of the work of the Health Inequality Strategy, and so therefore we would normally get on our meetings a review of a particular area. We had childhood obesity at our last one a couple of weeks ago, and also it's the area whereby we would also have some sort of oversight of the London vision, and there's been the plan is in our May meeting to have taken the vision and its strategy and turning it into as a more detailed implementation plan to understand how it's going to be delivered. And I think Sadiq, as Mayor, would see his role as a leader in health to make sure he's bringing that together. Not to performance manage each bit of the system, but to make sure that the whole system is working together and delivering the ambitions which we all share.
Just below that to add, which feeds into that, in that officer level, I chair London's Prevention Board, where this is the oversight mechanism for all of these tangible things happening. You keep track of them, you unblock them when you need to, you champion them when. So there is governance, and then there's one below that which is into the really granular detail of delivery. If we said we're going to do this, how we're going to do it, are we on track? So throughout those systems, you've got all of these partners being convened and bringing together in all of those different layers of the political and the officer. And that's why you get to this position 1 year on, which is we're on track to deliver what we said we were going to deliver, because we've got both engagement. And the culture, I think Neil's point is really important. The culture's right, about how you respectfully work with people.
I mean, the other, of course, thing is that public health has been where the budgets have taken the most hit, right, in cuts on public health budgets. But we're seeing some opportunities of growth there now coming along from the government. Is there a case, right, that some of the commissioning should be done centrally on things which affect all of London? Because I think when we had Mayor Johnson, he did ask for top slicing of the public health budgets to be given to London Assembly, but they weren't. But is there an appetite, for the councils to work collectively on commissioning things And is there an appetite within the London Assembly, with the Mayor, to do commissioning on behalf of the boroughs?
So I might answer that, but I might ask Professor Plant to kind of go right. So therefore, there already is a lot of pan-London working. And so the example, which in fact came from one of your members, Susan Hall, who asked us to look at hepatitis C as an example, which was done in 5 networks across London. And there'll be enormous benefit for this to be done, in a more collective fashion. Similar to work on TB, HIV. So there already is collective working. The mechanisms are already there that, if there is a credible evidence base of the benefits of collective working, one can do that.
I was talking about collective commissioning, right?
So
there's a difference between working and collective commissioning.
So therefore, and commissioning can be done on a pan-London basis, like the London Ambulance Service is commissioned on a pan-London basis. But at the moment, the Mayor doesn't have the present appetite to take on the commissioning of the health service.
So it's a perennial question. So go back to culture, because you get a lot further, a lot faster with more diverse delivery if you put it down rather than if you put it up. So the overall balance should still remain with boroughs. But the boroughs do commission the HIV prevention programme is commissioned across London. So when there's that case and people want to buy in, and once people buy in, people commit more, and it's more integrated with their local plans as well as the regional. I personally don't want to spend months trying to work out which of the various services we could commission. Some of them used to be commissioned before Pan London, before they went to local government, and I don't think there's any evidence that that's particularly a wholesale move, but there are some areas, and you may have some ideas as to where you're worried about some things which we can explore, but in general, I think my experience is collaboration trumps any sort of uniform top slice, because you just get into a whole set of different conversations and processes you have to work through to make it locally sensitive.
And I would say there is a significant example of pan-London commissioning of specialised services, which I know Vin is involved in.
So I can talk a bit. So I think firstly, NHS England and NHS Improvement, we are commissioners at a London level of a whole range of specialised services. But what we're very careful to do and what we're looking at the moment is to really be clear about which services is absolutely best to commission at a London level. And those are going to be services really where the number of people affected by those conditions, for example, is relatively small. And so you couldn't really commission at very small scale because you'd only be commissioning for 1 or 2 people. So services for children who are born with heart disease, congenital heart disease, for example. There are other areas where under the 2012 Health and Social Care Act, commissioning responsibility does sit at a London level, where actually we're starting to think, well, it would be better if this was done more locally. So things like kidney dialysis, for example, or services for people who are affected by HIV would be much better done locally, because the way medical advances have happened, it's much more local type services that we need. So we're very actively working on the moment actually on really being clear about what is it best to do at London level, what is it best actually to commission at local level but we can collaborate, what is it best to commission at local level but we need common outcomes and standards so that all Londoners get access to the same outcomes, and what is it really that would be much better done. And I think as a general principle, Paul's right, health inequalities, all the learning I've done in this role is that health inequalities are really located and nested in communities and in individuals. And so you have to commission and go to them and say, what is it that matters to you, and design your services around them, and not try and think we can sit back and do it for 9 million people in a generalised way.
Thank you. I'm going to ask Andrew, if you take over.
Right, thank you. I'd like to ask the people in front of us what they think are the best, most successful evidence-based interventions to tackle childhood obesity. Who wants to come forward?
To start, so the international evidence is that there isn't a sort of a hierarchy of a top 5. You're talking about quite complex systems. So what you do look at is what is the environment in which child grows up and has access to healthy food. What is the availability of that? So the intervention to get that would be very local. Going back to the localised, is if your high street in your area has a different composition and has a different set of issues driving it, the best interventions will be the ones who address your local issue. So how we nest this is, so PHE are working with national industry to take out sugar at source, because doing it once nationally is a good thing, but it's really complicated to do, and that's what we're doing. So that's a very good intervention which works. We've done it with salt already, and had big success in taking salt out of the national diet. Nobody noticed because you change people's tastes over time. And I think you can do it with sugar. So some of this is national. So advertising on TV is also national, but advertising in general is a real important issue. Therefore, the Mayor's leadership, the single thing when I've talked internationally to people about what we're doing on childhood obesity is the Mayor's banning of fast food, unhealthy food and drink on the TfL estate. So that would be a good intervention because of the sheer scale of numbers of people affected.
But we haven't done that, has he? He's only banned advertising of junk food. He actually allows junk food to be sold on the TfL estate.
You asked me for the evidence. So
yeah.
So what people see and are encouraged to consume is really important. Yeah. So we've got take it out nationally, advertise, healthy streets, and then you go into very localised communities, and the things we do in settings, with schools, really matters, and that's why in this strategy you've got such a big push of healthy schools, healthy early years. So there's lots of other things we could do, but just to be, other members of the panel might want to come in.
Vin happens to be a paediatrician.
I do. Well, so the first thing I'd say is I think at the London Health Board last week we had a presentation from the co-chairs of the Child Obesity Task Force for London. And they're of course independent and were there to provide advice, and they published their report last year which was based on an evidence search. And I think it, you know, speaking as a paediatrician, so with my professional hat on, I think it's an absolutely excellent document because it sets out in a very evidence-based way the things it calls upon all the different public agencies and the private sector to do in London that can help us prevent obesity, lead healthier lives, but also treat obesity more effectively when children become overweight. So I would certainly really, you know, support the calls within that. Their report was only published at the end of October, so in terms of doing, the next phase of work that we're doing as part of the London Vision is sitting down and saying, right, what resource do we need to think about putting behind this at a London level so that we have coordinated action as a city in order to move this forward. And the team that's doing that are also working with other global cities that are trying to tackle this problem in order to develop something like a global alliance, for example, where we could pull together and actually learn from other cities to learn what and create some of the evidence base in action, because this is a global problem and the evidence base isn't strong, but what the evidence base that is there I think is very well represented in the Obesity Task Force's recommendations.
So how many, what does the evidence tell us about how many obese children there are?
So in the information I sent through, I think you asked for it over the Christmas period. So we measure at reception and at year 6 in every single school, so we've got very good data. So by the time you get to the overall figure for London, who have excess weight, you're getting up to 40% at year 6. 40%. Okay. It doubles, as it does elsewhere. It's not just a London issue, between reception and year 6.
Year 6 being which age?
It's the transition year, so year 7 is the first year of secondary school.
And it's also it's greater in poorer children, and so whilst when I said earlier the idea of that London's a very healthy city, it's got a long life expectancy. but it's reversed for childhood obesity. So there we have the heaviest children in the country based in England, and the poorest children are the heaviest.
But what's the measurement of the levels of obesity that requires assistance, requires a particular attention? Because the 40% figure, where are these kids? Because I don't see them.
Could I just answer
I don't
that?
see them.
Well, I think what's been happening over a generation is as the whole population's got heavier, people have adjusted the sense of what's normal. It is not normal to be this weight.
And we divide into overweight and obese.
Yeah.
So the 40% figure, I think, is those children who are overweight.
And obese.
And the figure the figure for obese, I think, is 8%. Yeah,
8%.
or more. Than, yeah.
Not 40, 8% is obese.
No,
Overweight.
40% are overweight. Am I right, Paul? 40% are overweight.
Overweight.
And 8% are, and obese means that you're of a certain statistical phenomena away from the norm.
Okay. And what are these the figures that were based upon? There's some research done that says these figures are based upon what was an obese person in 1990. Is that data still the knocking around, or is it something new?
The base year. So it's based on physiology.
Yeah.
What we know about health in relation to being overweight, and we based it on a base year, so we can measure it through time. So
I still don't believe it. I just can't see them. I live in Barking and Dagenham, which is supposed to be one of those boroughs where obesity is there. And yes, there are obese children. I'm not denying that childhood obesity is a thing. But what I'm staggered by is this 40% figure. My husband's a teacher in Barking and Dagenham. He sees hundreds of kids, and I ask him, how many of those kids are obese? And he said, yeah, in a class of 20 to 30, one you would say probably needs attention. Not 40%.
overweight.
So 40% are overweight.
40%, yeah, overweight.
So, and these aren't the figures from, and so what you're questioning, which I can see, is that have we got a threshold to determine overweightness and obesity, which you think is wrong? We can only use what's the national figures. And when you're trying to track change and track what we're doing, you can't, it's very hard, you can't change your definition of what is overweight halfway through. So this figure has been accepted for a number of years, and over time we're gradually tracking it. And so therefore the ambition that Sadiq has is for a reduction in those children who are overweight by 10% by the year 2023. So that, i.e., if you look at the year that this was published, 2018, the year the child is measured 5 years later, can it be 10% less overweight?
Should our attention be concentrated more on those young people who are obese rather than those who are overweight? Sorry,
I just
Dr.
wanted
Flynn,
to
sorry,
kind
I'll
of
take
talk
it
about
back.
maybe the experiences in Hackney as a borough, because I recognise those figures of 40%. I recognise the difference between reception and year 6. And a few years ago, we were the most obese borough in the country for children. We've managed to reduce our figures, but only by including the ultra-Orthodox Jewish community, which is where there's a very complex relationship with poverty. They are a poor community, but they eat differently, and the children aren't, on the whole, obese. So those complex relationships with food and with mental health are very much entrenched. And the work we try to focus on as a borough is the early years, is pre-pregnancy, is having those conversations about food and weight at every opportunity, taking a MEC approach, making every contact count, to try to change some of those beliefs that within communities, to try to change the outcome. Because by the time that the child reaches reception and has that first NCMP, National Child Measurement, it's too late. The family are in those kind of eating habits. So we do want to obviously work with the child. We work with schools. We have the Healthy Mile, where children are walking for a mile a day.
I do not deny that there are young people who have problems. I'm not denying that. I'm trying to understand why I'm not seeing that scale that is described. Because the way to, if you've got a small number of people who have a health complaint, you address that small population. If it's a load of people, then the strategies are quite different to address that within a population. Take, for example, HIV. HIV advertising largely didn't work when it tried to advertise to everyone. It started to work more when that promotion concentrated on those people who were more susceptible to HIV. Similarly, with childhood obesity, I wonder whether or not we're just wasting our time on these advertising bans. I mean, do you think that the Mayor's junk food advertising ban is working?
So what we know is that the evidence shows that it's a mechanism which can work. Now, remember, it's very early on regarding how we measure these things. First of all, there's a lag. So the figures that we present to you now, let's say, on some of the data, will already be 2 years old. But what we do know is that overweight and obese children become overweight and obese adults. And that, in fact, it's much, much harder to get an adult who's overweight or obese to get them to the normal BMI. It's just so much more effective to prevent that adult and that young child becoming overweight in the first place. So when you asked for interventions, the one which is at the earliest is breastfeeding. So what you know is children who are breastfed are less overweight than children who aren't breastfed. The study in Leeds a couple of years ago looked at a programme of using early years to make sure children are ready for school, but to look at their diet and how can we make sure that the first 100 days are so vital to ensure that child doesn't become overweight in reception and overweight and or obese in year 6. So whilst I recognise your perception that you don't see these grossly overweight children, but what the evidence shows is the measures that we use for our definition of overweight, it shows that it's increasing, and that the consequence of being overweight as an adult is quite disastrous.
But if it's just a statistic rather than an objective assessment of whether or not that child has health risks, then surely that's a problem, isn't it?
No.
In terms of focusing.
I just going to bear out a linkage. So we know there's been a massive increase in type 2 diabetes. Type 2 diabetes, has got impacts not just for your kind of cardiovascular system, your strokes, your likelihood of blindness and kidney disease. We know that type 2 diabetes is linked to being overweight. We know that if you're an overweight child or an obese child, you're much more likely to be an overweight and obese adult and more likely to get diabetes. We've got over 1 million type 2 diabetics in the country. That is changing phenomenally. And as we track the increase in overweight and obese children into adulthood, they're the ones who are now becoming diabetics. So there is a direct correlation.
Okay. So you got to the point of we're talking about the junk food advertising ban. Is it working?
So we're doing an evaluation, of the junk food ban. From the evidence from around the world, we've been informed that this as a mechanism to reduce the inclination for children to consume unhealthy foods will have an impact on their weight.
So does that mean that the advertising that's been banned was targeting children?
So now I'm going to, because Paul's on the Child Control Task Force, so I want to make sure he answers it in a broader way.
So when any particular person wants to advertise, one of the particular questions asked is it targeted or would it be particularly impactful on children? It's one of the criteria used, so yes, basically.
So there were advertisers prior to the ban who were targeting junk food advertising at children?
Well, they never declare what they're doing. There was simply adverts on the estate, which now would no longer be.
But the effect on children is not judged as part of that ban, is it? It's just HFSS food, high fat, salt and sugar. It's not. The assessment isn't whether or not it's affecting children. Or
but that's what the independent.
So there is an evaluation being done.
Evaluation.
Which
It's
will
too
look
soon
at
to. but the independent evaluation will look at that specifically.
Well, you know, the reasons for the ban, which I'm assuming you were involved in recommending, were worked on the basis that you felt that some of those advertisements were targeting children. Is that what you're saying?
As in, yes, and they were in families where it was...
So you're saying some of the adverts that were on the tube and the transport network were targeting children?
Would have an impact on childhood obesity.
They would have an impact?
Yes.
They weren't targeting children. Were they targeting children?
Well, you're asking for a global answer to some very... This is a very specific advert by advert policy which looks at each of these proposals to advertise on an individual basis. That's what happens. Somebody comes forward and somebody says that, and it's judged on those grounds.
So the number of children who are on the tube is about...
But you're asking a question about...
Sorry, I thought you'd finished. I'm sorry.
So go on.
I'm trying to... You see, this was on the basis... If this was put on the basis that those ads were targeting children, then it's clearly wrong. But you're saying that you think those advertisements had an effect on children. Is that correct?
These were unhealthy items of food and drink.
So are you resigning from that statement that these were targeting children?
So can I come in?
Yes,
So
please.
I think, firstly speaking, as a paediatrician who sees children who are obese in the clinic, the first thing is, in terms of the discussion that I would have with a parent and with a child who's obese, the first thing is most food that children eat is not bought by the child, it's bought by the parent. So in some senses, having a detailed discussion about whether advertising is targeting an adult or targeting a child is a moot point, because actually obesity and being overweight and eating habits are cultural and they exist in families.
Right.
And so the critical bit about this, I think, is whilst it's a factor, it's not the whole factor. And the really important thing about this ban is it's reducing the environment in which our families are living that allows them and it better enables them to make healthy choices about what they're going to eat. And that's the critical bit about it.
So it's not targeted at children, this advertisement, it's targeted at the parents, is that correct?
The ban as itself is a ban on the estate, so it would affect all Londoners.
On the estate, and the advertisements that were existing beforehand were wrong because they targeted adults, or was
It's
it
not so
general?
much- it's not so
Because
much-
we told this was about... You see, the thing the Mayor's been saying is that this... I'm sorry to spend some time, but I've never been able to connect the logic of this. Is that the Mayor's going on about childhood obesity, yet only 5% of the users of the transport network are children. He says that it's because... He's stated that it was because all these advertisers were targeting children, but I'm unable to get a statement from you that they were targeting children.
So I think it's almost like...
So this is why I'm...
Andrew, you're almost asking us to answer a question on behalf of the advertisers. So,
well, the advertisers have a clear code, which means that they are duty bound not to advertise to children. And yet you're saying they were obviously falling short of that code. If the advertisement ban was based upon...
I mean, I think, to be honest, it's more kind of a set of kind of simple steps, which is that the food that has been advertised, we know if consumed significantly will cause childhood and adult obesity. We know that the people who are travelling on the tube are children and adults. We know that reducing the advertising of food, tries to reduce the obesogenic environment and has an impact on reducing childhood and adult obesity. And by removing that advertising, therefore, you're following the logic to say we're going to create an environment whereby when the children, albeit 5% of the travelling public on the TfL network, are there, they're not being exposed to foods which will promote childhood obesity. And that is the logic of our argument.
Yeah,
and the evaluation that we're doing will demonstrate
changing the
its
entire users' mindsets about food.
We're trying to ensure that children and families travelling on the tube, wherever possible, are not exposed to an obesogenic environment. And what we've looked at other cities, like in Amsterdam...
Was it on your recommendation that the Mayor used the HFSS criteria? Whose recommendation?
I think it was the public health a professional advice was that this was the most...
From who? Somebody gives him
The
professional
nutrient
advice.
health profile is a recognised way of doing this objective.
Sure, but who gave the Mayor the advice on that, to use that?
I think at the time it was Professor Yvonne Doyle.
Right. So I'll try again. Do you think it's working?
Well, we keep saying that we're doing an independent evaluation rather than
Do you
relying on
think the fact that on the tube at the moment I can take you to advertisements for fried chicken, I can take you advertisements for burgers, I can take you to advertisements for wraps, all on the tube network. On that basis, do you think your assessment of the junk food ban is going to be positive, or is it going to be negative?
I'm a scientist, I'd wait for the evidence.
If you saw that it was advertising those products on the network,
I
clearly
think there's
you can go down to London Bridge now and see those advertisements now on the tube network.
Okay, so there's two bits to this. So if you as an assembly member, when we come to review, you don't think it's working because there's loopholes, we can consider that and we can revise how it's done. So if that's what you're saying, we can take that as a challenge and we can look at that.
Yeah.
But I don't want to go back to it's an independent evaluation and give an independent less than 1 year on to something which is...
Well, it'll be 1 year on next month.
But the evaluation is going to take longer than that.
Would that be some time after the next mayoral election, possibly?
We can find out when the evaluation will be published, and we'll obviously share it with you, because it is learning we need to have. And when you choose which nutrient profile you want to use to make the assessment, it's got to be as objective as possible. And you've mentioned a few things which, you say, well, that doesn't fall into that criteria. To try to have introduced a whole new set of criteria to assess what should or shouldn't be advertised, would have been so difficult and challenging.
We'll move on to the next question. We'll move on.
Was this criteria used by any other city around the world?
It's
No,
used
you obviously said this is an international criteria. It's obviously been used somewhere else in the world, right?
Used throughout the UK.
Throughout the UK. Has anyone else had difficulty with this criteria?
Not that I'm aware of.
Well, come on. We've implemented something in London, right, which is a national criteria, right, which has been used elsewhere.
From this?
What I'm trying to say, right, are we having a unique experience in London, or was this something predictable? Has something else had the same experience?
Therefore, the criteria, and so first of all, what I would say is we can get you further information on this to share the criteria, but I think there's always debate about when you're choosing a set of criteria which you want to measure your advertising ban against. You say, what is the one which has got the longest history of use, the most evidence behind, recognising there won't be a catch-all for what everyone perceives that, it's missing popcorn, salted popcorn, as an example. But it's been a widely used criteria.
Which has a long history, which you say is reliable.
Correct.
Which will be used right, which will be used elsewhere. But all I'm asking is, did those
These
who have implemented it have similar experience? And if they did right, what do they do about it?
Can I just say London's the only city that has instituted such a ban, so actually that...
No one else in the world has been done.
Well, not using... This is a UK profile, so that nobody else would have used...
So no one else has done it?
I mean, earlier, Dr. Coffey, you said you want other cities to take London's lead.
I do.
Well, that's fine, except that we've got absolutely no evidence to say that this ban is working.
But we're doing assessment on top, Andrew.
But I think what you'll find is what London's lead...
Why would somebody take our lead at the moment, bearing in mind you can find all those adverts?
Because we're using the advertising ban was based on the evidence that we gleaned from international sources to say, what do we think has an impact on the consumption of food? The evidence showed advertising to families. Therefore, we decided we're going to be bold and show political leadership, and where the evidence took us, it was to ban the advertising of unhealthy food.
And using the HFSS profiling method.
Correct.
Did you comment?
I was just going to, I mean, I think Tom's probably said what I was just going to say, but I think it is important that we do take those bold statements, because if we don't, nothing will move, it seems to me. And then I think you're right, you have to assess whether it's working, and it may do, and then we'll all say carry on, or it might need tweaking. But Tom, you're going to say something about Amsterdam, and I was just, when you were cut off, and I was just wondering if that was relevant to the point you're making.
So Amsterdam have a programme looking at childhood obesity. It's probably 3 or 4 years older than the UK, and they again have had one of those things whereby the multifaceted approach. There isn't a single idea. You say, if you do this, you will address childhood obesity. And what it required was leadership from the leader of Amsterdam, collective working, and addressing all those interventions at every stage you can. Breastfeeding, first 100 days, nursery education, walking to school, more restriction of kind of advertising, more access to water. And therefore, we very much try to learn from the Amsterdam model, because they, again, so this isn't the development of a policy in a vacuum. We're trying to use where it's been done elsewhere.
Dr. Coffey, I'd like to recommend that you read the report that I produced, which was very much in support of a lot of what Amsterdam did in terms of addressing childhood obesity. And of course, when it was assessed that this was successful, this was well before an advertising ban was actually introduced in Amsterdam. So those successes were delivered without the waste of an advertising ban. So I understand where you're coming from, and we, curiously enough, want to slay the same dragon. I think, however, that you are wildly hurling missiles into the air, assuming that you're going to find the problem everywhere, when actually what we should be doing, like Amsterdam, which is have a targeted approach on young people who are susceptible to childhood obesity. Let's move on to another section. What are the challenges facing the boroughs to deliver interventions to tackle childhood obesity, and what could the Mayor do to support those boroughs? Who would like to answer? Yes,
Should I start
Mr.
again?
Coffey. Sorry, Dr. Coffey.
Okay, so obviously colleagues will come in here. So if I look at, say, a few examples, right? So first of all, I would say the Healthy Early Years programmes, which Joanne's very aware of, which tries to make sure the measure we're using very much is school readiness, but also that programme tries to make sure we address kind of children's access to food and eating and dental care. Then there's the Healthy Schools programme, which also has if you look at ages of 5 to 18, an approach which again, this is very much. It's kind of supported by the Mayor, created by the Mayor, but delivered by the schools and local authorities. The third area I would suppose talk about is what the new idea of super zones, whereby the 13 boroughs have adopted some projects regarding school super zones of 400 metres around those schools to try to create the environment which addresses air pollution, an environment which is non-obesogenic, which also encourages walking to schools and increasing exercising and reducing weight. The fourth one I suppose I would talk about is a proposal now to introduce water-only schools, which has been done in a few schools. And when it was done in America, what they looked at was, initially the plan with the water-only schools, the idea was that what it might do is reduce childhood obesity. But in fact it had 3 other benefits. It improved dental care, it improved behaviour in the class, and it improved childhood outcomes. So it goes, there's 4 projects that the Mayor is trying to develop pan-London to allow the local authorities to implement these projects to try to address childhood obesity. I might ask colleagues from the boroughs and from Public Health NHS who might give other examples and how it feels.
I'd also support the Healthy Early Years and campaigning for public health budgets, because we commission health visiting services, and that's the really most important first point of contact, and then obviously that continued contact for those vulnerable families. So that would be extremely important. I agree with the water in schools, potentially a sugar ban in schools, I think there's very variable policies in schools, and I think there's more work that could be done there. The healthy mile that's been adopted in some boroughs, again, just changes mindset for children and families around the importance of exercise, but actually changing exercise to be non-competitive, because I think, you know, schools can be very much, you're in the sports team or you're not. And the beauty of the healthy mile is that everyone has to walk or run. It doesn't matter. You just do your mile every day. And I think that's something that could be taken forward.
Are you saying that the schools should be mandated to put in such schemes, or we just need more of them
they
to
could be
take them up?
encouraged.
Encouraged.
And I think
Absolutely right.
it's not always possible. Some schools don't have the playgrounds, but you know, we've managed in Hackney with very tiny playgrounds. We thought of some quite innovative ways of doing it.
Mr. Churchill, did you want to speak?
So I just wanted as well to say I've been very impressed by some of the community-centred programmes like the Community Champions in the 5 West London boroughs who've been doing that, which don't start from the position of here's a problem, what are you going to do, but actually what do you want to do in your community, but targeting people on estates that we might not have a good connection with, or parts of the population where we find harder to hear. And when I met a lot of those Community Champions, a striking number of them are focusing on exercise, weight, diet, either in the school environment or the community environment. So I think that there's an energy in those communities. I think what I found from those schemes, it was good for the NHS because they were groups of the community we were not doing as well at engaging, and it was very good for a lot of those people. And in the evaluation, also saw that 75% of those people had been unemployed when they started, and got jobs as a result of the skills and confidence that they built from going through it. So that I think it's a community-centred approach to something.
It's basically more sort of granular and focused initiatives seem to be producing good results.
Yes.
How could the Mayor encourage that to take place, do you think?
Well, I think there is a conversation that we're having across London about how we might build on volunteering and community engagement approaches which have worked very well in certain London boroughs and try to make that London-wide in some key areas, and I think this is one of them that we're working on with Sir Tom Hughes-Hallett and others.
Yes, yeah. So there's a number of layers to it, I think. I think from the NHS's side, local-based approaches are really important. So again, I think, you know, if you're a GP or you're a nurse and you identify someone, for example, a child and a family who needs support, actually local boroughs, the voluntary sector, the early years, the schools and their involvement in encouraging a healthy environment is absolutely critical to it. And that's where actually the Mayor's policy around social prescribing and promoting social prescribing and being able to have those families not have a medical solution, but actually have a service, a voluntary sector group, a community, something being run through their local school that actually enables them to develop healthier habits, that enables them to stay healthy, is going to be a much better set of policies and things that we can do. The second thing is actually, I think the early years were the Assembly and the Mayor's led, both with schools and early years, is something London can be justifiably proud of. When you look at the literature and look around the UK, the work that we're doing in London through this, I think is the only place that's really matching it at the scale with the sort of size of population that we have in London is Scotland. And Scotland are a bit further ahead of us because they started their early years collaborative about maybe 2 or 3 years before we did. And they're showing evidence, as Dr. Coffey says, of improvements in dental care, in mental well-being, in family cohesion, in employment and so on through working very directly with schools in some of these areas. So they've got massive potential. And you know, we can't force, nobody can force schools to do anything because most of our schools in London are part of academies or part of large chains. So working with them in a collaborative way and spreading and adopting good practice and creating a bit of a social movement behind them is actually the way that we're going to get change to happen.
Thank you. The Health Inequalities Strategy set target of 10% of early years settings signed up to the Healthy Early Years London programme, and that's been achieved. Was the target ambitious enough, Dr. Coffey?
When we initially set it, I think it was, but and because we were anxious that there was no longer that strong lever from local authorities, from the GLA, to say, how do you get schools to do this? You're working with the willing. And the early years settings, they're very busy, So therefore, we had to just make sure there was a programme they would just see such worth in that they would wish to adopt it voluntarily. And therefore, when we said 10%, we had a big debate about it. Was that too ambitious? But in fact, the approach that Vin has just mentioned about things kind of spread because of people want to do it rather than being told to do it has been much more effective than we imagined. So yes, now we've achieved it early, and rather than saying we were unambitious, I would say we were very successful.
Okay, that's reasonable. I'm not going to argue about that. You're going to set a more about ambitious target, do you think?
I think we need to review that to make sure, because we always want to stretch ourselves, and Joanne's giving the leadership on this,
you should be there.
Okay, no. And so therefore the credit very much goes to the team, which Joanne leads, and people in my team. So I would imagine we'll review the target to make sure we're as ambitious as possible.
Yeah. I agree with you. Targets should be achievable, not just aspirations.
Yeah.
So I absolutely agree. We've been made aware that the uptake of HALE scheme has been lower in certain boroughs compared to others, and I wondered what the Mayor will be doing to removing some of the barriers to getting more people involved in the programme.
So when we looked at the boroughs, there were 17 boroughs that we really wanted to make sure were engaged. We said, who are the most deprived boroughs? Because you mentioned earlier the idea that we should be having a targeted approach rather than a universal approach in certain areas. So we decided to target it. So therefore, there are 17 deprived boroughs, and all 17 of those deprived boroughs have now signed up. There are,
excuse me, when you say the boroughs are signed up, does that effectively mean all the schools in that borough?
No. So therefore,
the support of the local
what it would
authority.
be is that, and so I don't want to stretch outside my knowledge here.
Yeah. So you're absolutely right. It needs to be targeted on the most disadvantaged and deprived schools serving those. So the 17 have been achieved, but so the delivery model is very much, as we keep saying, this engage, support, unblock. So I think it's the right challenge. The 17 working with local government now is really important because it is a wider partnership, so it's not just what the Mayor's office can do to unblock. So basically, if we think there are gaps in particular areas, there'll be a conversation with the borough lead first rather than just going over the top of people. So basically, we're alive to it. It's still the ambition to go faster and deeper and more extensive with that eye on the inequalities element. But it's almost, the approach has always been go and listen first. Go and listen and find out. So that's the basic approach, but it'll match to. My experience of these sorts of things is they snowball, that once people can see success, so show people success, don't tell them what a good scheme might be. So the more we circulate that, I think will unblock you can do it in deprived areas. Look at this school here, and I know the team doing the healthy schools. It's a particular approach to sharing that good practice, circulating it around, networking people in to unblock very specific issues for very specific schools.
We've heard some evidence that actually to sign up to HALE it can be a little bit bureaucratic. Is that something you recognise and something that might be attended to?
I think I'd have to ask the team deal with it, but we're always open to, if that's the case, then we'll listen and respond.
Do you want to ask a question?
I was just, I don't want to give evidence, which is difficult, but I just want to set the record straight as well, that I just go along and visit what the team's done, and it's the health team, not the education team that's responsible. But I think one of the things that has impressed me to go and visit it is actually it's not just schools who have this in their raising debt, but it's actually those private nurseries as well that are signing up. I think one of the benefits is that it also matches the Ofsted framework. So actually, if settings follow, they actually are going through the requirements for the Ofsted framework for their settings as well. So I think that approach really works, and I take it you believe that that's actually would be one of the successes.
And I think that was probably one of the reasons as well why the rollout was quite successful, is that when Ofsted looked at the criteria and the curriculum within the early years, the HEL programme, they recognised that if you were able to become HEL compliant, that moved you very closely to being Ofsted compliant as well.
Mayor has introduced a ban on hot food takeaways within 400 metres walking distance of primary and secondary schools. How is that working out?
So I think that the planning guidance, I think it's part of the London plan, and I'm uncertain about the implementation to be at such a level that you could assess it at the moment. I think that it's going to committee in February.
Yeah, so it's not implemented yet. So it's
Not
proposal, and it's new, not all.
New.
So, it's going through it's been through the examination in public, so we don't have implementation yet.
Should it be implemented? Have you got mechanisms in place to measure the success?
Which
The
is
success of the
implemented
policy.
is the policy.
Yes to both questions.
You're going to have mechanisms.
So there's going to be an evaluation.
How does it square with the Mayor's professed intent on preserving the high street?
I think if one was suggesting that you were going to close down these shops, or if you were going to say that we're going to have no new retail units open, I think that might have an impact. One thing which you're trying to kind of look at different policies. I imagine, and I'm looking at other policies regarding promoting of cycling and walking as one of our health and all policies about maintaining health. And I imagine ensuring that people cycle and walk around their neighbourhood might make them more likely to shop in their neighbourhood. I think that would probably encourage the high street.
And finally from me, you'll be delighted to know, or for this section anyway, I'd be interested to know what the Mayor and the GLA are doing with regarding to talking to your partners in the food and drinks industry to improve health in London.
I have no contact with the food and drinks industry. Whether other officials do, I don't know, but I personally don't have any contact because my day job is as a government official in the civil service, so I wouldn't do anything.
We have a food team which I know do work with the food industry. I'm the independent chair of the Child Obesity Task Force, is working with the food industry to see can we explore options of changing menus to make sure they're healthier. We have a number of large kind of companies which provide fast food within London. So but they are having a discussion as an independent chair. I'm not aware of discussions that the chair. I'm not saying they might be happening. I'm not aware of it.
Dr. Clements.
At a local level, we work with local pubs to try to encourage interesting non-alcoholic beverages, and that includes working with our town hall catering as well. So that's a small step, but for the City of London, obviously, that has quite an impact.
Do you think it's quite important that we have a dialogue, or that you have a dialogue with the food industry?
Yes.
You do? So, would you be supportive of talking to companies like Danone, who produce formula milk?
I think I would talk to any company if I thought it would improve the outcome for children's health.
Because many of these companies want to be part of the solution, but feel as though they don't really nobody talks to them because they're evil.
So nationally, PHE have engagement exercises which go through not on an individual firm by firm, but by sector. So there's an even-handed way in which we would engage with them on reformulation of their products to take more sugar out their diet. So we have a lot of engagement, but it wasn't me personally, it's nationally by sector, and it's not an individual company. It would be an invitation to a number of companies to engage.
But companies like Danone say nobody talks to them. And they're producing...
I'm not part of that
a lot
team,
of...
so I would be very surprised, given that we are talking about sugary foods.
Yeah, but generally it's a good idea to talk to people, talk to the producers.
But that's to say, nationally we have a whole team of people who do it in PHE, because we think it's at that level a company is more likely to reformulate its products.
To get the policy out. Thank you very much. Thank you for that. Thank you.
Thank you for that. Ramesh, over to you. Thank you, Chair. I'm conscious of the time, so I'll try to go through my questions as quickly as I can. Let's sound is right. So there are some employment-related issues here. So if I could ask you, Dr. Coffey, and you, Mr. Kabi, Professor Plant, given the fact that more than 1 in 5 Londoners are currently receiving less than the London living wage, what are the Mayor's plans to ensure that those in low-paid sectors and/or insecure contracts are able to access the support they need to stay healthy throughout their employment? And following from that, does the Mayor's employment improvement programs, do they work in a joint fashion with borough efforts to create jobs?
Okay, so my level of involvement in this is very much from the health perspective, but linking your question to the previous question by Andrew, about kind of addressing in-work kind of poverty is an issue to address childhood obesity, but also poor mental health, poor physical health. So the projects that we're involved in, so the one I'm supposed to is the Healthy Workplace Awards. So therefore a plan to say how can we make sure that working with the 1,000 organisations, in fact 1,053 I believe, so 50 more than our target, which I'm very pleased about. We're trying to make sure that we can get those industries to see that their employees are more likely to be productive if they're healthy. So we look at their physical health and their mental health. And we're very aware that we've got to look particularly at people who are on lower incomes. And so therefore we're now trying to do targeted work with the London Healthy Work Awards on small companies and companies who have people on lower incomes to see can we promote within those industries improving of their health and therefore also maintain the company's productivity but improving outcomes clearly for those employees. That's the kind of work I know we're doing from the health area.
That's my involvement is to see the health. I know the Mayors are doing wider work on the London living wage, but just in terms of the healthy work, the other element to that is to pick up the mental health dimension. So when it was reviewed, it was reviewed with a view that that was a particular dimension which needed to be strengthened. So that's all I'd add on that.
Can I add, which is I think a related area, but I think one of the things we've been concerned about is the extent to which young people get the chance to be involved with the NHS and learn skills and find out about routes into employment. And true to some extent, if people wanted to become doctors, there were ways for that to happen. If they wanted to do other things, there weren't. And so we've been really working on trying to increase the number of opportunities for young people to get involved. And one of the things we are going to be doing quite soon is launching NHS cadets, targeted at 14 to 16-year-olds, which will have elements of first aid training, so building on the work that we've done in London, but other things as well. And we are going to be particularly targeting young people from disadvantaged communities to come into the ranks of NHS cadets. So we think that there's a way of broadening out the number of people who are either coming into the NHS from more disadvantaged communities, or they're getting the chance to learn skills, build confidence by working with the NHS, and that will be a big focus in the next year.
Thank you. Can I come back to you, Dr. Coffey? I mean, my second question about the mayor's programs work aligned with the boroughs. Is there any evidence of that? Can you give us some examples?
I am not aware if there's a borough-based work on the Healthy Workplace Award scheme, but I know that it's spread throughout London. A lot of the organisations which are part of it, in fact, go across many different boroughs. I know for local authorities, they, like you, recognise, that, paying the London living wage and addressing poverty is probably one of the biggest things you can do to improve someone's health. And so with health and wellbeing boards and the work plans which, take place on boroughs are trying to mix, those two key aims together. Experience in Hackney might kind of give examples.
Yeah, so we really welcome the Healthy Workplace Awards. That's been a really good way of us actually having a conversation with businesses, because without that we don't have any leverage. We've started quite a long time ago in the city through our organisation Business Healthy. The challenge has been to work with the SMEs. So within the city, over 95% of businesses are actually SMEs. They don't have the capacity, so I really welcome that new tool that will help us actually engage with them and actually make something workable. I think, going back to your first question about the low-paid workers, we're worried about the nighttime economy and those workers, the cleaning staff in offices, the security staff. Trying to engage with those companies, though, who employ them often on 0 hours contracts, that's where the challenge is for us, especially in the city, because those companies are based outside the city and they're much less easy to engage with. So any help engaging with some of those big companies would be really useful.
And one thing which the Mayor has recently received, I think, the devolution of the London adult education budget, which is, I think, 350 million. And he's really trying to make sure that he uses that budget to focus on low-skilled workers, workers who've got an additional complex need, be it a mental health issue or a physical disability, to ensure you maximise their potentials, to use the budget to improve their skills so they stay in work, but also progress in work to improve their wages.
I was going to come to that, but you answered my question. And thank you for that's food for thought. What you talked about, because I represent Tower Hamlets and the nighttime economy bordering Hackney, and also represent the City of London. So it's certainly something that I think we'll go and think about. So I think that's a very important point. So this is to all of you or some of you. I mean, are there examples of other employment improvement schemes that Mayor could run that would better target low-wage, low-standard sectors?
Dr. Allen, you can answer this question.
Yeah, there's plenty of examples. I just think this is such a critical area for all kinds of inequalities in health outcomes. So there's low pay, there's quality of work, there's access to employment, so that involves transport and so on. And the more that can be linked with all the other issues. So, for example, just in terms of obesity, we were just talking about, we know that if you were to follow the Eat Well guide for healthy eating, that would take 70% of people's income after housing costs in the bottom decile. So there's some really, really serious issues. So I think with low pay, and I see there are some mechanisms in place, but it's absolutely critical. So that's one thing. The quality of work, I mean, poor quality work is almost as bad for health as unemployment, which is really bad for health. So again, there's a huge amount, the case to be made in terms of kind of the advocacy and convening role that the Mayor has. In terms of persuading employers, it's beneficial for them, but it's hugely beneficial for the workforce and for all these wider health outcomes of the NHS and so on. And there are examples from other places where effective strategies have been done, and we can relay some of them.
And the biggest employer in London is the NHS. And the NHS, I think, are now taking much more seriously their need to look after their own staff. And there are things called clinical quality improvement kind of funding schemes within the NHS now, which focuses on the well-being of their staff. Because many of the NHS staff are quite lowly paid, and therefore you want to make sure that they're as healthy as possible, to not just kind of ensure they get the health benefits, but the health service gets the productivity benefits.
I mean, you make the point, Coffey, that the NHS is a good employer.
No, it's a big employer.
It's a big employer. Then do you want to draw that distinction before I draw that?
No. I'm just saying what I said, but it's both a big and a good employer.
So just take it further, and of course, the NHS will look after its own staff, but in terms of supply chains, are public sector partners in London doing enough to use their supply chains to create good employment opportunities, living wage jobs, the sort of things we've been talking about?
I think it's changing, isn't it? I think that policy shift to viewing particularly the NHS but other public sector bodies as anchor institutions in a community, and the economic impact and social impact is growing. I mean, if you look at Barts and the Royal London, they've got big programmes to do this in local communities. So I'm personally seeing more and more of that happening from more and more health institutions. How far it gets through to your point about the supply chain is complicated, but I do see an increased commitment to do it. The other bit of this, which is I think also important, is people with mental health problems getting into work, because London loses too much talent, because lots of those cohorts of people don't get into the work or they fall out of work, and I think that's recognised in sort of a devolution deal which the boroughs and partners are taking forward to try and address that. But it's certainly, I know from the NHS trusts as well, they're recognising that to keep people well you have to look at those bigger issues including employment, and they've got bigger programmes to do that.
Yeah, you may want to.
I was just going to come in on the supply chain side of things. I think the other side of the anchor institutions work is the social value work, where a lot more has been done in local government than in the NHS, but we are very interested in the NHS about how you can use contracts in order to try and influence the supply chain and to try and build on that anchor work. So that's something where if there are suggestions or learning that you could point us to, we'd be very interested to look at that.
Just to add to that, universities, there's lots of other large anchor organisations in London that could be doing this much more effectively, as well as the NHS.
I mean, it's not a new area. Local authorities, amongst others, have used procurement policies to further wider social objectives. So my final question to you, Dr. Diwakar and Mr. Churchill. So you may be aware of Industrial Action as a teaching hospital which is affiliated to St. George's NHS Trust by outsourced security workers whose terms and conditions are far worse than in-house NHS staff. Do you think NHS organisations have responsibility to practice what they preach on the wider determinants of health by promoting good employment practices for all their staff?
So shall I come first to London? So I think just building on the point that Professor Plant made, I think there's increasing interest from particularly our biggest NHS institutions in this particular bit. So as Professor Plants mentioned, we know that there are good examples of institutions like Barts, like the Royal Free, like Imperial, like Guy's and St Thomas's that are specifically looking at this area and looking systematically as anchor institutions at how all their procurement and their employment policies and so on, and particularly as contracts and so on come up for renewal, particularly looking at the social value that those add. So that's a very active movement that's currently going on in the NHS, and in fact those institutions I've listed are collaborating with the national team in NHS England because this is a commitment that's been made in the long-term plan to look at the social value elements of the NHS as employer. I'm afraid I can't comment on the individual elements of the case that you mentioned, since I'm not directly involved in those, but if there is information we can give you afterwards, I'll be happy to do that.
And what I would just add, I think that the commitments that we will be making in the NHS People Plan need to be for all of the people in the NHS, and I think recognising that the crucial role that people play in other than clinical professions or managerial professions, those are often the people that patients will talk about that made the biggest difference to them. So I think it was a very well made point, we're certainly alert to it, and I think we need to see what we can deliver through the book.
Thank you. Steve?
Okay, good afternoon. I'm turning to healthy places, built environments, high streets, etc. And I commented earlier, it's great we've got so many guests, but we perhaps could have had someone, an architect with a London plan in the corner there as well for the Mayor's 8th floor would have helped, because I'm going to ask 1 or 2 questions around that, but I'm sure that the panel might be able to respond. So it is noted that people's built environment has a contributory factor to their health. This committee and others have taken a keen interest in that subject. So first of all, question probably to possibly Tom and Paul, others can come in, really about what progress has the Mayor made on using proposals in the draft London plan to improve health and reduce health inequalities. Colleagues.
So, and again, I think you're right that this question probably would be better answered by one of our planning experts. But so what I'm aware of is the example which Andrew gave regarding using the London plan as a vehicle to address childhood obesity, the 400 metres rule. One of the sections, I think it's called policy GG3 in the London plan, which is called about creating a healthy cities. And that is the kind of approach the London plan is using. So where is the evidence about what we can do within planning guidance to create a healthy city? And so that's been put in there. And it's probably got 2 impacts. It's setting a clear message that the built environment is important for health. It's about the space you get. It's the ensuring that the provision of the appropriate housing, the way we design houses, the way we design our environment. Secondly, part of the London plan has in it, I think it's called an environment impact assessment process, to make sure, therefore, for all new developments, part of the process that you'll go through is to assess that development about creating a healthy environment.
I'd see that as completely expected.
Yeah.
Can I just, I don't mean to stop you full flow, but your first point about GG, whatever it was,
GG3.
Does that shout out very strongly from the London plan about health, or is it tucked away with 2 lines?
No, to me, it's shouted loud and clear.
Well, it would to you, but is it a firm statement about the health aspects of the London plan, and this reassured you and others in the...
Yeah, no, I think it does, and in fact, so as the health person for City, I often go meet the deputy mayors to make sure that they're really bringing alive the idea of health and all policies. And I have to say, my job is done for me, and I go and I meet deputy mayors for transport, for environment and for planning, and they really get it. The idea that they can use their policies to improve the health of Londoners. And that idea of GG3, is the thing which puts a very clear strapline about this plan. It's about creating a healthy city.
So this is the emerging London plan that's going through its iteration. Because I would ask you an unfair question. Has there been any large-scale developments that have been refused because of a contrary to health benefits? Probably not yet, you're about to say.
No, to be honest, I'm not aware of the detail of that, to be honest.
Okay, that would have been kind of helpful. Perhaps officers can pursue that, whether that actually has been the case. I mean, on that same theme, I'm sticking to the built environment. I'll get onto streets in a minute. I've got a colleague on my left who's far more of an expert than me, and you'll be pleased to know Andrew probably will join the debate. But let's talk about family-sized homes. I mean, it is pretty clear that family-sized homes are probably a healthy way to bring up children. Does the London plan speak specifically to that? What's your view on that?
Again, I'm unaware of the detail of that. And to be honest, if I had known in advance sufficiently, I would have probably researched this and got it back for you. So what I'll agree to do is, and hope someone behind me is taking notes on this, to make sure that that question is asked, because you're making a very important point that the living environment of a person in their house contributes to their physical and mental health. Yeah. If we're not building accordingly, we're not doing what we can do to ensure that improves. So
Paul's bursting to come in, I think.
Likewise, I'm not in favour of the detail, but there are 13 design policies which sit below that particular overarching one, which includes good quality housing and minimum space standards. So below that big commitment that this is a complicated area to get right when you're looking at a particular place within a particular planning application. Below that there are other design policies which will speak to that.
Complex, it's a complex area.
Yeah, so there are those design policies as well, including moving on from that into social infrastructure and how you create a healthy place by what's surrounding the house as well as what's the size.
Yeah, I was going to get on to the green space aspect as well, but I think probably, and it's probably my fault because I should have asked through the office of the chair that perhaps somebody from the London Plan could have been here, but perhaps another time. So let's move on, if we may, to green spaces. So it's recognised again by most experts and people like me who aren't experts that green spaces are healthy for mind, body and elsewhere, and that's recognised by the industry. So again, how do you, I think probably anyone may join this, how do you feel London and the Mayor is progressing protection of green spaces or encouraging green spaces or use of?
If I just start, I might ask colleagues and what Nicole said, what's Hackney's doing about this. So we had a session only about 6 weeks ago when we discussed the green city. And first of all, I gave the clear evidence of the link between a green city and the physical and mental health of adults and children, and not just we go noise pollution as well from a green space, the impact on air pollution of green space, the impact on exercise. So there's a really clear evidence base for what you're saying. Also, so the Mayor is doing a number of things to increase the amount of green space, and it's about accessible green space. So, and London, in fact, has got quite a lot of green space, but it's not all accessible. Secondly,
I recognise the last two bits. There's lots of green space and lots not accessible. Are you referring to the tree planting, or what I'm
focusing is about how, in the developments that London is taking place at the moment, they are increasing the amount of accessible green space
within the developments,
and also a thing which I think it's very much a very symbolic measure was when in July last year, I understand London became a national kind of a green city. And whereby a National Green Park,
and that's to be celebrated,
right? And that is something which I think indicates a direction of travel. Again, I can very clearly give you the benefits of a green city on air pollution, health, and my environmental colleagues probably would be better versed to give you the detail of what's happening to ensure that. But what I'm aware of is that there is an increasing amount of green space, accessible green space in London, and that is being supported by, I think, something called the Green City Fund.
Yeah, okay, I've got that.
Did you recommend that?
Sorry, please,
just to add, the evidence base is very strong, we know that. But safe green spaces, so safety is a real issue. So unless there's support in those green spaces to ensure safety, people aren't going to go to them.
Yeah, and hopefully that's recognised, Dr.
I think in addition, encouraging people to actually use those green spaces. So, we run free or very cheap exercise classes, £1 exercise class using our parks. That's a cheap way to encourage people to actually participate and use those green spaces.
Yeah, London does have some wonderful green spaces, including a fair degree of green belt in other parts, and with another hat that I've got, there's encouragement for green belt to be used and opened up. Let's get back to existing housing. So much existing housing is probably recognised as substandard by today's standards and contrary to health, mental health and physical health. What's the Mayor doing around that? May I ask you both? And is he addressing existing substandard housing and the effect that has on ill health, mental health, inequalities?
I might.
You're going to say the same thing, aren't you?
Because so I can give you the evidence of, as you well know, the impact between poor quality housing of the existing housing and poor outcomes for health. I probably wouldn't do justice to describe the housing policy of the Mayor, and that's probably much more rests with the housing team. But
you have a view probably that you would agree that London has a degree of substandard housing that has a detrimental effect and needs addressing. But Vin, Doctor, you're nodding your head. May I?
Well,
think that's true.
That's right. I'll take that. That's fine.
No. So I concur with your assertion about the benefits of improving any substandard quality housing in London.
Okay.
But can I do justice to give you a detailed answer about the initiatives that the Mayor is doing to address that? Yeah. I can't, but I can get you that initiative.
Can you get?
I think it would be helpful. There's one or two questions I've asked that probably people need to write to us. I think.
Yeah, that's fine. And so, sorry that we haven't been able to do that.
I understand. I'll ask you my last sort of section about the health. I think some touched upon Healthy Streets, the Healthy Streets scheme, which is a mayoral initiative that does permeate through to London boroughs and elsewhere. Perhaps Nicole can comment on that. Would you be able to perhaps your experience in Hackney?
I'm not sure that I could also do justice to this question because I don't know enough about it.
I'm not doing very well, am I? Okay, fair enough.
So I do know,
Tom, talk to me about Healthy Streets.
Healthy Streets.
Oh, you know something about that. Well
so I think there are a number of design principles behind a healthy street.
Yeah.
Okay, and it's just about first of all about safety. Is you can create the people have got to feel safe. So it's about lighting. Mm-hmm. It's about shade. About places to rest. It's about air pollution. About traffic and noise. So there are a number of principles behind creating a healthy street. Second, I know that the super zones, which are around schools, which I mentioned to you, which have been piloted in 13 boroughs, part of the things which schools are encouraged to do is create those healthy streets around their schools. Thirdly, what I am aware of is that there's been 80 healthy street officers being created by Sadiq, and these are 18 people who work within the boroughs, trying to develop with those boroughs opportunities and the implementation of the Healthy Street programme.
Right, okay, so are they planners or traffic engineers or what do they do?
I haven't got their job description. Okay. All I know is that they are people who will support the borough to deliver the Healthy Street initiative.
Yeah. Okay. I mean, as a borough person, I know the Healthy Streets initiative does inform planning applications, road layout, etc., to some success. I think
but it's not a simple thing about, make it wider, make it brighter, make it safer, make it lighter. It's all those things, increase the shade. Elderly people, when the consultation was around the Healthy Street, very clearly said they need places to sit and rest. If you're not going to put benches along the street, elderly people will not walk along those streets. If it's not well lit, it feels unsafe.
Yeah. No, I've got experience of that in Croydon where there's encouraging footfall. So access, it's more access that people can walk from places.
Some engagement we're going on to find what would encourage more people to walk and cycle at a more granular level than just the London level to inform implementation at the local level.
I get that completely. I think that's me.
Thank you. Sure.
I want to ask about healthy communities and in particular about loneliness and social isolation. And we know from the evidence that it's particularly acute amongst older people. But I've also been reading some surveys with young people lately, and it surprised me actually the level of loneliness amongst young people as well, particularly teenagers.
The evidence shows that.
Yes, and so I was wondering what the Mayor's Health Inequalities Strategy is doing about that and what effect it's having.
So if I start, and colleagues will probably chip in. So the evidence which came out a couple of years ago was the link between loneliness and not just poor mental health, but early death. So elderly people who are lonely die earlier than people who don't have this, have a much wider social support. And one of the key drivers to social prescribing was the addressing of loneliness in older people. To those patients who I see as a GP and oncologist as well, who often the key issue for them isn't their hypertension or diabetes, it's their social isolation and its impact on their health. The social prescriber, so Sadiq has supported from the outset, one of the key deliveries is kind of how can we address loneliness. And that means not just the GP identifying it, the social care navigator, having a discussion, is having voluntary sector organisations which can support loneliness. And so Sadiq very much is very keen to support the voluntary sector and Team London and the volunteerism throughout London to provide an infrastructure to address loneliness. Secondly, the point which, it came to me a bit later to realise that loneliness isn't just present in older people, it's younger people, it's often young families. And one of the initiatives I noticed the Mayor has doing is looking at something called the London Together Fund, using sport to try to address loneliness. Also, there's the London Family Fund, and this is a fund which is being used to identify parental isolation. So often, a parent with a child at home may see no one throughout their day because of the isolation, that may come with having a small child and low income. There's something called a Young London Inspired Grant Fund, which also tries to ensure that we young people who often, it isn't about having friendship groups, it's about social resilience. And with social resilience, you're more likely to have larger social groups and therefore more likely to get into work and to education. So there's a number of little pots of money which the Mayor has used from all age groups, from families and single people, to address the loneliness. But also there is some work, is what's called a small grants programme, which is being used to fund some voluntary sector organisations which social prescribing can refer onto to address loneliness, befriending schemes of Age UK and the like. So it's something which I think over time we'll see as a bigger issue in larger cities with millions of people, social isolation. And I think the impact on health is more significant than we realise, and that we do have a responsibility as policymakers and decision makers to develop policies which can address that and improve people's health.
I'm aware of all those pots of money you've talked about, and they're really welcome. But actually, it's what I think, on top of that, it's what we can do strategically to embed some really good practice and schemes for the long term. So can I ask perhaps Dr. Allen and Dr. Kleinman what you perceive as this? And what more the Mayor could do?
Just one thing that is I'm flagging up is youth services. And I think it's right to identify loneliness in young people as increasingly, at least we're increasingly aware of it as a major issue. And it has been a focus through social prescribing on older people. That's not necessarily applicable to younger people. So, but one thing is the cuts in youth services, which have been really, really damaging in all kinds of ways. There's an association with violent youth crime and increasing social isolation among young people. So I think that's an area where perhaps there should be a really strong focus for all kinds of reasons, of which loneliness in young people is a part. Early years centres reaching out to young mothers in particular, who, as already been mentioned, are isolated. And I just want to flag up the role. I know the Mayor has some programmes in place around mental health workers in schools. I think this is absolutely critical, and how they can link up with other services that are available. And then another point about housing. So we know that people in poor quality housing are much more socially isolated and lonely, and it's partly because they don't want to invite people around because their house is, in such a state that they're embarrassed. So there's a whole kind of raft of things which are good to do in their own right, but also good for a whole range of other health outcomes, of which loneliness is one. But the particular one I wanted to flag up was youth services.
I think just to stress the importance of knowing your communities and actually doing some work around London on different particular communities. So children's centres for us have been brilliant. We take a whole school approach through mental health and have the mental health workers in schools. But one population I wanted to flag up is LGBTQ and suicide rates. Now, I think with the work Thrive London Suicide Group are doing to get a London database, maybe we'll be able to get some data to know whether this is a trend or not. So I only flag it from an audit that was done through East London Foundation Trust. We can't do it because we can't get that level of data, but obviously they know their patients and they can get that data. And there was a spike within their audit, and I just think that's a real concern. That's generated some local work, but I think that particular population, is that an issue around London?
Yes, so I think the issue of young people. I think we always talk about this often isolation term in terms of older people, which is a real issue, but young people and LGBTQ plus as well. And I've seen documents where they have been flagged up as a really vulnerable group. So I think it's, how do you then embed that into the strategy going forward?
Just briefly, 2 points. So absolutely, and it's come up through Thrive constantly as one element of number, and that social movement with 200,000 Londoners being involved with Thrive in some way, the Mayor's leadership and support for that, to do that listening and do that sort of social engagement to find out what the different groups want, I think is part of that sort of leadership and convening role, so I think that's really powerful. There's some other way Vin might sort of talk about a bit more from the London vision. There's conversations happening about a bigger engagement and volunteering and the role of volunteering throughout the 10 areas of focus in the vision, which again, so a lot of the conversations we've had this afternoon, there are always other outcomes you can hit when you do this partnership working at the multi-layers, and so even though specifically the Mayor might not want to say something specifically on this issue, the other programmes are definitely picking it up very, very practically and in a very engaged way with Londoners right in the heart of their communities.
I just wanted to add that I think there is a challenge for us all in trying to measure some of this about who is it getting to. So taking in volunteering in NHS, we know quite a bit about how many people volunteer and what kind of things they do. We know much less about who they are and their background, and so we do believe that the people who might benefit most from volunteering in NHS are probably least likely to volunteer in the NHS. And I think, again, with things like social prescribing, there's a lot that we want it to do. It's a big programme, but who's going to be benefiting? Is it going to the places we expect it to be? So a sense about understanding where is it reaching, where is it not reaching, talking to those communities about how we can improve some of that is going to be really important.
That's helpful, and I note that last year the document Next Steps for Social Prescribing in London was published, and as part of that there was going to commitment to establish a new advisory group and appoint a new regional facilitator. Has that been done, do we know?
To be honest, I think there's an advisory group. I can't answer whether there's a facilitator appointed yet or not, but I can find out for you.
I think what happened was that sort of Mayor's leadership early on is that the NHS long-term plan then commits to putting in link workers through the primary care network. So there's a growing infrastructure to link the local government, but based in the NHS where there's different resource. So I think some of that, the conversation is, what would a regional coordinator do if the NHS are coordinating in different ways? So it's absolutely right, there's a commitment, it's absolutely right, it's a priority. And the really positive thing is the NHS is saying we'll put resource into this and we'll start funding link workers and we'll start training them and we'll start engaging with local people, and we're just at that cusp of.
So I was going to say, so I think there is a small team. So rather than it being a formal post, it's a group of individuals that we've pulled together and made it part of their job to lead on this. Some from the NHS, some from local government, some from the GLA. And as you say, the NHS actually is making a major investment in social prescribing, so we'll have 206 primary care networks in London over the next few years. It will be a lot of work, I think, to create them, but part of that is investing social prescribing in those, and we've got some really clear objectives about what we want to achieve. As Neil says, the challenge then is measuring the effectiveness of social prescribing approaches. The other element to it as well is actually just developing not just the evidence base but the learning around social prescribing and what it means. So the setting up of the new National Social Prescribing Academy and actually making use of some of the assets we've got in London in some of our universities where there's an evidence base behind it is going to be important. I think the other bit, just from the loneliness, going back to the loneliness piece, I think certainly just speaking for me personally, two of the most important things I've seen, I think, over the last year that have come from the Mayor have been his leadership and the GLA's leadership around Dementia Friends, and very powerful stories about the number of TfL staff, for example, who are now trained as Dementia Friends, members of staff here at the GLA itself. And secondly, suicide awareness training and the movement we've got. So, 5,000 Dementia Friends, 5,000 people doing mental health first aid training. Really impressive stories from the Met and from TfL staff about places where they've intervened in people that go to the estate with the aim of harming themselves, and where they've intervened and been able to signpost them. So I think there is some policy alignment across a whole range of different areas that I think will end up tackling loneliness in individual bits. And absolutely right.
And I would argue that, in fact, the advocacy role that Sadiq played, the Mayor played on social prescribing, was reasonably successful amongst others throughout the country, where it became a national policy in the new GP contract. And the role we've got to play in GLA now is very much about what things are better done once for London. But there are numerous primary care networks, a number of boroughs, a number of practices all having their own navigator. And the focus I think we're going to perhaps look much more about is the appropriate the training of navigators, the digital and IT systems which allow navigators to share information between themselves and the voluntary sector, to make sure the voluntary sector throughout London is able to receive the referrals from social navigators and has the capacity to do so. And working with Bromley by Bow in Tower Hamlets, looking at how they perhaps use their social welfare advice system, because a lot of people who are coming to social prescribing often need social welfare advice services, and that will become a new avenue to have that supplied. And we're looking at how Bromley by Bow provide it at the moment and get that learning for across London. So it's very much focusing on what can we do once for London, what can we learn and roll out for social prescribing.
I think those last few answers, I've had all my questions answered actually, but I think Che, it would be useful actually just to get in writing some information about social prescribing, how you're going to measure the growth and evaluate its effectiveness. That would be really
We'll arrange to do that.
helpful.
Thank you.
And can I just ask finally, from Dr. Kleiman and Dr. Allen, is there anything more that you think the Mayor should be doing to make London an age-friendly city?
Age-friendly?
Yeah.
I mean, the transport's the obvious one.
Yeah.
In terms of there's some really basic things around traffic flow and traffic management, but also public transport. I think we've touched on the loneliness element. Things will occur to me as I...
Bound to. Please let us know if there is. Yeah.
Yeah, I think encouraging the dementia friends, because I think the older, potentially housebound people are still at risk. And I don't think they're necessarily engaged in some of the programs that we've been talking about.
Thank you.
Thank you, Virgia. I'm just picking up on the social prescribing. Probably by Bow, right, is a very unique centre, Tom. 2.5 acres of land or site were given by local authority to put on all those people, okay? You won't find any other example of such a site in London, okay? And so I would be interested to know what learning have you going to take from that which you can take over to other parts. Secondly, the PCNs are giving one social prescriber per PCN. And the evidence we heard, right, that the best type of social prescriber navigators are those who are embedded in practices, right, where they have a regular base, right, where they can be seen by, where patient can be referred to and prescribing. So I think Bromley by Bow is not an example, right, which can be replicated in London very much.
So if I'm trying to say, so one of the big learnings, I can remember a discussion about 18 months ago with colleagues from Tower Hamlet. So there was two schools of thought. One said that social prescribing, what you needed was to refer the patient as a GP onto his website, let him work around the website, and they can work out all these lovely services. Then we thought that if they can do that, they've done it anyway, right? And the second school of thought was the ones from Bromley by Bow, saying, do you know what is important is the social interaction, the human face-to-face contact with the patient and the social navigator, the latter one today. And that was because of the strong evidence from Bromley by Bow to say you can do this. And it was not just Bromley by Bow, it was Tower Hamlets. They said for £1 a patient, about £300,000 for that borough, you can implement social prescribing. And that, I think, was the learning which we took forward and is now as part of the national policy, that we're funding a person to do this who will meet the person, not just, say, go on that computer. The second issue is about, is the resource being spread too thinly? I can speak from my experience, the answer is no. My primary care network's got 3 practices. We've got a social prescribing navigator, and she's based in all 3 practices, and she sits in a room. I can book her onto my GP system, so they are part of the team. And I think the thing you're saying is that referring to somewhere else to go, it won't work. Patients tend to prefer to go to their own practice. They come and see your GP. If I say go next door tomorrow to see the social prescribing navigator, they're more likely to turn up. These are patients who are often vulnerable, and you need to make the referral and that referral journey as easy as possible, face to face, next door, in a place that they know.
And the example I want to refer to is number of Ealing. We have 78 practices. In my PCN, we have got 14 practices, right, and 1 social care prescriber amongst 14 practices. And that's a challenge you have in your practice. So the point I'm trying to say is that London is not uniform. You will have inequalities of healthy prescribing, social prescribing, okay? And we need to be mindful of that, okay? That we need to be making sure that that inequality doesn't increase, right?
And in fact,
inequality access to services is an inequality.
And PCNs can increase their investment into social prescribing navigators. The larger the PCN, the larger the budget, the more you can do that. But I accept that if you've got smaller practices, trying to do it per site makes it more difficult. But I would definitely advocate that it's a face-to-face interaction in the practice possible.
I accept that, right? Okay. But I'm saying that there is this whole discrepancy across London. Okay. Just to come back to the last bit, right, okay, which is about healthy living, right? Given that the strategy doesn't include any KPIs on drug, alcohol, or gambling addiction, how is the Mayor measuring progress towards his HSE objectives to reduce the use of harms caused by tobacco, illicit drugs, alcohol, and gambling? Given there's no KPIs on these issues, how are we measuring progress?
So I'll pick up some of that. So in terms of tobacco, that is in the London vision, given the essential importance, and there are sort of ambitions being worked through in respect to that. So all of those issues are important, but that is in terms of an inequality one. So there's significant progress since the publication of the Inequality Strategy and the delivery plan to work with partners and progress that, particularly around things like illicit tobacco, where at a pan-London level that's probably useful to coordinate and orchestrate action as well, even though the actual activities are at a local level. We've got big commitments in the long-term plan around tobacco and how the NHS is going to support people from that. So in terms of that one, I'm confident that it is being picked up. I think
I'm confident about tobacco.
Okay.
I'm confident about tobacco, but I didn't just focus on tobacco. I focused on gambling, drugs, and cable drug and alcohol, and gambling. Right? I know that smoking is being picked up, and it's picked up in the cough data, and we're collecting all that.
Is
right?
it you worried about a KPI, or you worried
yes.
about action?
Or how we progress? Because one of the things with the Health Inequalities Strategy says is that it will be want to reduce these things, right? But there are no KPIs to measure it. So how will we be monitoring that is what I'm assessing.
We certainly monitor, and we monitor through the public health outcomes framework, and we work very closely. I mean, don't forget a lot of those in terms of the commissioning of services, they're local government, and it's the local government responsibility to commission services for drugs and alcohol. So it's not that they're not measured, and we do know what is happening in our communities. I mean, as ever with any strategy, you prioritise and you focus your attention. But if what you're saying is you'd like to see those, I think we're at a stage of reviewing the strategy just over 1 year in. Yeah. The delivery plan was only for 2 years. So if the recommendation is that we look at that, we can certainly do that.
The Health Inequalities Strategy promised establishing a pan-London illegal tobacco and counterfeit alcohol team. Have we made progress in doing that?
So a business case has been developed, and the sort of how it would operate has been developed. It's part of the London vision, therefore the actual funding of that is going to be taken forward in terms of that. But
so hopefully it'll be established within the next year.
Yeah, well, that's a decision for multiple funders, but what I'm saying is the development work has progressed that particular issue, working with local boroughs about what would it do and how would it add value.
Yes.
The conversation's been actually, and was part of the original devolution discussion, which is for the Exchequer nationally, that must be a good thing.
Yes.
To actually reduce the amount of illicit tobacco in London. So that was the conversation with that. Yeah. So we've progressed it, but it's not in place.
Okay. The other thing, of course, smoking rates are declining, but it's becoming increasingly concentrated in certain groups. And those groups are difficult to reach, and the disparities between the boroughs have increased. How are we addressing that?
So my team do a lot of work with the boroughs on that. They've got very localised, focused work. It goes back to you have to.
Some boroughs have stopped commissioning cessation clinics.
Several have not. What they've done is focused on the most disadvantaged, difficult clients. So what they've done, rather than provide a universal service, they've done exactly what you're suggesting, which is to target it. So at a pan-London level, we're supporting people on that very specific, how do you work with communities who are not responding to globalised, I think it was your point, globalised messages, and so that is getting to very granular, and I know that the directors of public health and their teams, this is a big priority for them to understand and work on, almost estate by estate on these sorts of issues, and it's part of that community engagement, part of that understanding, hard-pressed lives, what's the health priority for some of these communities, and how best to support them.
I was going to say in the NHS long-term plan there's a particular focus both on tobacco and alcohol. So for tobacco there's a model called the Ottawa model, which is a model of there's evidence that when people are in hospital who are smokers who have a health problem as a result of their smoking, that they respond quite well, but they need very, very intensive support. Particularly, as you say, smoking rates have come down, so actually what we're not really talking about is smoking, we're talking about nicotine dependence, which is difficult. So there's an investment going in, relatively limited in year one, but it will gradually be phased up over the next 5 years that we're coordinating jointly with Public Health England so that every hospital will have access to the Ottawa model and an intensive smoking support team, and then working at a local level, making sure that's linked in with the local services that are commissioned by the local authority. I also know a number of local authorities are also starting to map their the location of their smoking services according to things like the incidence of children's asthma, for example, because we know of the association with that. In a similar vein, there's a similar programme of work going around alcohol and alcohol support teams. There's another model that can be used where, again, if you really target people who have problems with alcohol dependence when they come into hospital suffering a health problem and invest, and again there's a phased programme which will be evaluated because the evidence based around alcohol support teams in hospitals is less strong than it is for the Ottawa model.
Yeah, and on tobacco there's a particular focus on people with long-term mental health problems and working with the Mental Health Trust in terms of supporting
maternity as well.
Yeah. And so the mayor's role is very much again about convening and being a partner, because as you pointed out, smoking cessation services were passed on to public health at local authorities a few years ago, and it's their job to commission services accordingly. But we are part of the Smoke-Free London Alliance,
yes.
And our role will be to do whatever we can to convene and support. I know last week, I think, the Make Every Contact Count Link London was launched. And that's the idea whereby it's a website to say that, if you want to log on to it and find out where are your local services, and very, very much from hospital staff that and clinical staff like myself can use to find a patient who says they want to stop smoking now, use the opportunity, intervene, and that kind of pan-London website can tell you where to go.
Yeah. Thank you. Dr. Evans, what more could the Mayor do to support health and social care providers and local boroughs to tackle the issue of smoking and substance misuse? What more can the Mayor do?
So it's me?
Yes, I will.
I'm not sure I'm best placed to answer that.
Okay.
But an integrated health and social care system is obviously going to be preferable. Sorry, I don't think that's my...
Okay, is there anyone else who wants to comment on what more the Mayor can do?
I think it's encouraging different at-risk groups. So we're doing, and I think in London we're doing quite well, but we could do better on CO testing in pregnancy, and then directly referring those women to smoking cessation services. So just making those links. I think MecLink is fantastic. All the London boroughs have participated, and we'll be using our navigation services to redirect people. I think one of the challenges is not the tobacco, it's the cannabis that's entrenched in some communities, and I think that poses a very different problem because those people don't want to go to any smoking cessation or substance misuse services, and I think that is a problem for London and for young people.
Good.
May I, very specifically on that point, the Mayor has called for an evidence-based conversation about cannabis, about the law, about how it is enforced, and how we support those struggling with addiction. I wrote to him and I said, that's the best thing you've ever said since you've been Mayor. But has he involved any of you in that conversation yet? With regard,
I've been involved in the discussion very much about, where would you wish to get evidence from? On the medical side, there are obviously a lot of people who are experts in this field, from drug and addiction services, mental health services, respiratory physicians, and the impact of cannabis on respiratory function. And the approach I think he would want to consider is making sure he has got a wide array of experts as possible to say, if I'm going to move this debate forward, what it needs to have is the evidence. And so I can talk from the health side, but I'm aware that obviously there'll be a further discussion with experts in the criminal justice system to equally find out the impact of changes to kind of any process around the supply of cannabis.
thank you for that.
Thank you. Good. Thank you. The other thing, of course, that talking about the healthy workplace rules, the Mayor is to be congratulated that he's got 1,000 organisations signed up, right, and it's done very well. But how can we stretch that target and get more companies, particularly SMEs, to sign up?
I think one thing we do need to do is to make it easier, because we want to make sure is that to ensure we're assessing the award and how it's achieved, there is an infrastructure to it which a large organisation might find it easier to do as opposed to a small one, is to try to adapt the model. So for small organisations, employees of 10 or 20, can we have maybe even a slightly different approach of how they access the award? Especially because some of the lowest paid workers are in the smallest organisations. And therefore, if you want to address health inequality, you've got to make sure that any barriers to accessing that scheme are limited, and that approach we're considering.
Thank you. We're almost towards the end, right? Is there anything else that on the areas we've covered, right, that you wish you'd said something to us? So there's an opportunity to say this now. Or if you remember later on, saying, I wish I'd said this. This is
what do you know I would like to say something? I've got a list here.
You can always, I'll ask yes, you can write into us.
No. Just, I'm the suicide awareness training.
Yes.
Of the fact that, we've got 40,000 Londoners now having completed suicide awareness training, which I think is phenomenal.
Yes.
If we want to address suicide in London, we've got to increase that up to 100,000 targets.
This is the wrong way around, I'm sure. Sorry, very briefly, this is such a detail at this stage of the deliberations. On item 7, you talked about of your health inequalities indicators. You say the suicide rate gap between men and women, and you show a gap of 4.2 to 13.4. Should that be the other way round?
Sorry, I can't see the piece of paper you're
I beg your pardon. It's the.
Do you want to write to? Because it would be my team who.
All right. It implies that The suicide rate amongst women is greater than men, and that's not what I've understood from.
It's higher in men.
Sorry about that.
I mean, you was right.
Oh, well. Yeah, thanks. Will right.
Okay. Tom?
Yeah, I was looking at the graph which Andrew was indicating for, and I think you're correct in the assertion that the suicide rate in London amongst males is much greater than amongst females.
Yeah, it is. Good.
Thank you.
Figures need switching around.
You were talking about.
I was just jesting.
Okay. Yes. Okay. That's super. Okay. Great. Look, thank you very much for all your contributions. If you do remember that you want to you'd say something, please feel free to write to us. So, can I ask the committee to note the contribution of our guests?
Noted.
And also to note that the report and the subsequent discussion and delegate authority to me as chair in consultation with the deputy chair to agree any output from the discussions. Okay. Can I ask the committee to note the progress on this work programme and the topics agreed by the GLA Oversight Committee on the 17th of December for its meeting of the March 2020? Okay. The next meeting of the Health Committee will be on the 11th of March at 10 o'clock in the chamber. And there's no other urgent business, so therefore, it's the end. The gavel is to tell